I have a question. You walk into a patient's room and they say hi to you and they're talking to you. Do they have a pulse?
Yeah.
Yes.
Of course, yes.
So we can assume that they have a pulse, right? You don't have to check a pulse to say, oh, I need to check your pulse. Excuse me. Are they breathing?
Yes.
So I don't know why I felt like I had to ask the question.
No, what were our exams saying?
It was an exam question.
Oh, no, I was gonna say it wasn't on anything like that. No, I was just asking for the one. Yeah, for the blood pressure.
That's why when I go into this, like if Kim is watching, or like out. Like immediately outside, I'm like, oh, so you check the patient's phone. That's why.
Yeah. So if you're going into the patient's room, for what was like, are you verifying that their airway is in place, you're ventilating them correctly?
No, just like when we're assessing the patient, part of the patient assessment. The only part of it, he said, like, I want to check the patient's pulse. And you know when you want to so that's why.
And then do you chart that, like patient's pulse feels ready?
I don't know, we don't do that big, but if it's ready or bounding or not. You just
So
want to
what,
get the practice.
right, so what do you do with that information?
She said she wanted us to be that way because the monitor can lie and not be the right heart rate. But in theory, we don't need to actually monitor our pulse size.
Yeah, so got to make sure that your assessment fits the reason that you're in the room. So if you're going into the room, it's the beginning of the day, and you want to make sure that your patient is being ventilated correctly, their airway is secure. Should you be checking the ankles for edema at that point? I mean, is that an important part of your morning assessment? So maybe she's telling you it is, and then if she is, okay, I understand, but just think in the back of your mind, you want your assessment to fit what you're doing with the patient. So if you're called to a code and it's now becoming check pulse, questions, do the airway. What are you going to be doing? You're going to be checking the ankles for edema. So you want to make sure that your assessment fits what you're doing in the patient. All right, so we're going to start off with talking about junctional arrhythmias. So an arrhythmia, dysrhythmia, means the same thing. So last week we talked about atrial arrhythmias, so abnormal rhythms that start in the atria or start with the SA node. So now we're moving down to the AV node. So the AV node is not receiving an impulse from the SA node. It'll start generating its own impulse. And if it does, it's called a junctional rhythm. So that's the takeaway from like the first 6 or 8 slides. So a junctional escape rhythm has a slow rate. It'll be between 40 and 60 impulses per minute. It'll usually occur when impulses from the SA node fail to reach the AV node. So the AV node will generate its own impulse. P waves are not seen. Sometimes they can be inverted. And the reason that P waves are inverted is because instead of the atria depolarizing from the top to the bottom, they're depolarizing from the bottom to the top. A retrograde depolarization, yes. Sometimes the P waves show up after the QRS. So this is a junctional escape rhythm, and when you look at it, you can see that it's really slow. And how do you know it looks slow? You see a lot of boxes between each R wave. And then looking at the regularity, it looks regular. And then you look for P waves. Yeah, there is a P wave. There's one before each QRS, but it's upside down. So when we see an upside down P wave, we know that the rhythm started near the AV node and traveled up through the atria. So slow rate, upside down P wave, we're looking at a junctional escape rhythm. Where's my little... Okay, name the rhythm at the top. So we've got 30 boxes. I can see by these little red lines coming down because that's 15, 30 boxes. So how fast is the rate?
50.
Right, 50 per minute. So you count the number of R waves, multiply by 10. Do we have P waves? No. Is the QRS normal?
Yes.
Yeah. So what rhythm is that? If it's a sinus bradycardia, we would have a P wave and a normal PR interval. So it can't be sinus bradycardia. No, absent, inverted.
It could be absent or inverted.
Mhm.
Okay, so they're both examples.
An example of,
Junctional escape rhythm.
yes, junctional escape rhythm. So this one at the bottom, same thing. And then we see that the P wave is inverted. So we know the rhythm initiated from somewhere near the AV node. Then the rhythm can start speeding up. And when it speeds up, it's called an accelerated junctional rhythm. So again, no P wave or it's inverted. But you'll notice that the rate is fast, not fast. It's like a normal sinus rhythm kind of a rate. So that's called accelerated junctional rhythm. And here's an example of it. So when we look at it, we're looking at 6 seconds, 1, 2, 3, 4, 5, 6, 7, 8 times 10. So the rate is 80 per minute. And when we look for P waves, we don't see P waves. So how can you have this fast of a rhythm and no P waves? Well, no P waves tells us that the rhythm started near the AV node, went through the bundle of His and right and left bundle branches perfectly because we see a normal QRS, but no P wave. So that's a junctional rhythm, but it's not 40 to 60, it's faster than that. So we call that accelerated junctional rhythm. No, just another example. So we would look at 6 seconds, we would count the number of R waves, multiply by 10 and come up with the rate. And then when we look for P waves, we see there are none. So we would come to the conclusion, we're looking at a junctional rhythm and it's 60, between 60 and 100. So we would use the word accelerated.
They don't have to have T waves either.
That won't help us say that it's a different rhythm. But yeah, this is weird to not see a T wave.
So you wouldn't see one with this, or you would, you could. Still.
You could or couldn't.
Okay.
Yeah, to identify the rhythm, whether you see a T wave or not see a T wave doesn't make a difference. It would still be the same rhythm. And then it can start going really fast. So if the rate is between 100, 180 per minute, now it's called junctional tachycardia. So here's fast rate. How fast is the rate? Okay. Oops. All right, so no P waves or upside down P wave. You know that you have a junctional rhythm. Next thing you do is figure out what to call it. When would you call it a junctional escape rhythm? How fast would the rate have to be for you to say, oh, that's junctional escape rhythm? Very good, 40 to 60. And then the rate is 60 to 100. What do you call that? Accelerated junctional rhythm. And what if it's faster than 100 per minute? Junctional tachycardia. Very good. Another example of the same thing. Okay, so that was it for arrhythmias that start near the AV node. Now we're moving down the heart to the ventricles. The first abnormality that it talks about is a bundle branch block. What is that called when a bunch of words start with the same letter? Yeah.
No, that's the
Bundle branch block. Yeah, I thought it was called something really weird. An obliteration or no, alliteration. Anyway, there's an obstruction of the electrical impulse passing through the right bundle branch or the left bundle branch. The result is that one side depolarizes later than the other. It will cause the QRS complex to look abnormal. And here's an example. It looks like the letter M because the impulses are going through the right bundle or the left bundle branch quicker than the other side. And that's what splits it and gives it the look of the letter M. And then this is just looking at a sinus rhythm. And the only thing that's abnormal about it is the bundle branch block. All right, next we're going to talk about PVCs, and the letters PVC stand for premature ventricular complex. It's always called PVCs when you're at the hospital. Nobody sounds out each word, so PVCs. It's a premature ectopic impulse that originates somewhere in one of the ventricles. The QRS complex will be wide. It's going to be more than those three little boxes. And then if it's from different abnormal sites in the ventricles, all the PVCs are going to look different from each other. So it says here they will vary, pardon me, they will vary in size and shape. Okay, and then we'll look at what bigeminy is, we'll look at what trigeminy is. 3 PVCs in a row is called a run of Vtac. And Vtac stands for ventricular tachycardia. All right, now let's look for pictures. All right, so we see PQRST, we've got an inverted T wave. PQRST, these look normal, this looks normal. And then all of a sudden we have this really big, wide, bizarre looking QRS. It's upside down compared to the others. So what's causing this? So this is an irritable area in the ventricle that initiated an impulse and caused the ventricles to depolarize. So an ectopic area in the ventricle initiated an impulse, and that caused the ventricle to depolarize, the ventricles to depolarize. So looking at the strip at the top, we see a normal PQRST, and then we see a big wide QRS. So that's called a PVC. That is an irritable area in the ventricle that initiated an impulse, and it's spread throughout the ventricles abnormally, and that's what makes it look so wide. So PVC. So we have a normal conduction and then a PVC, normal conduction, PVC. So when there's a PVC, every other impulse is called bigeminy. So every other impulse is a PVC, is called bigeminy. And then the bottom, where you've got two normal conductions, and then a PVC, so it's every third one is a PVC, and that's called trigeminy. All right, ventricular tachycardia is always called Vtac at the hospital. Rarely do they say both words. Patient is in Vtac, get the crash cart. So Vtac, oh, I already have it up there. So ventricular tachycardia is considered an unstable rhythm. It can quickly deteriorate and the patient can go into cardiac arrest. So anytime you see ventricular tachycardia on the monitor, you don't take it lightly. Like, oh, let me put that in my notes, or, oh, I like that, let me run a strip. There's going to be an urgency to get the crash cart to the room and have the defibrillator ready, because the patient could go unstable within the drop of a hat. So it's a very unstable rhythm. So I know you guys had this on your exam, but what can cause the ventricular muscle to be irritable? Like, why would it start behaving erratically like this? What are some of the causes? Low potassium, low oxygen, and ischemia. Very good. So low potassium, low oxygen, ischemic muscle, if it's not getting its blood flow, it's going to start behaving erratically. It's possible to have ventricular tach. Oh, I didn't show you the picture. So this is ventricular tachycardia. It's a really fast rate. And pardon me, it's all wide QRSs, one after the other, really, really fast. So sometimes the patient can still be awake, alert, and have this rhythm. And that's called stable ventricular tachycardia, or they can have this rhythm and have no pulse. So we're going to go through both situations. So this slide tells you what the treatment for Vtac is. If the patient has a pulse, there's time to give a drug to stabilize the ventricles. And the drug is called Amiodarone. As far as memorizing the dosage, no, you don't have to memorize the dosage. The mechanism of action for amiodarone is it affects the sodium, potassium, and calcium channels. So the action potential when the muscle cell is depolarizing and repolarizing, it kind of makes those channels slow down a little bit. It also has alpha and beta adrenergic blocking properties. So that's going to slow down the heart rate. So that's how amiodarone works. So if the patient has a pulse, neurologically, they're still awake and alert, there's time to give that medicine via an IV. Also, there's time to, instead of defibrillating them, cardioversion can be done. And again, the difference between cardioversion and defibrillation, with cardioversion, it's a lower dosage and it's synchronized with the shock being delivered during the QRS. So that's cardioversion. So there's time to do that, and hopefully that will change Vtac over to a sinus rhythm. You can see Vtac on the monitor. The patient can be without a pulse. They're going to be unresponsive, of course, if they don't have a pulse. And that's when you would start CPR. So starting CPR right away is important, but what's even more important is defibrillating as quickly as possible. And I never knew this when I was first in the field. And of course, respiratory responds to a code, and our job is to get compressions going, get the airway going. And I could never understand why the nurses are trying to push us out of the way to get their defibrillation pads on the patient. It's like, can't you see I'm trying to do CPR here? And then of course I learned that no, the quicker the patient is defibrillated, the better their chances of converting back into a sinus rhythm. So that's why they were trying to push and get their paddles on the patient. So the faster you defibrillate, the better outcomes for the patient. All right, and then it talks about different types of defibrillators. You hear defibrillators being called monophasic. Those are old defibrillators, and biphasic. So what's the big deal with those? A monophasic defibrillator delivers shock in only one direction. So one of the paddles will be sending the shock through the body, and the other paddle will be receiving the shock. So that's monophasic. Let me put that in the chat. So the monophasic defibrillator delivers a shock in only one direction. And for that reason, you need more energy. So 360 joules is a normal amount of energy. If the defibrillator is biphasic, that tells you that both paddles are sending a shock into the patient's body. So that's biphasic. So both paddles deliver a shock. So because both paddles are delivering a shock, not as much energy is needed. So the maximum energy setting for a biphasic defibrillator is 200 joules. So after lunch, you guys are going to demonstrate defibrillating a patient. So in the hospital, as far as what falls under the policy and procedure for respiratory therapists, we don't defibrillate patients in the hospital. However, when you're going through your ACLS course, you need to be able to properly defibrillate. So you're going to demonstrate how you would defibrillate, just to get you ready for your ACLS course, and also to understand what's important when you're defibrillating. So you started CPR, you got the defibrillator, you immediately defibrillate the patient. What's next? It doesn't say it on the next page. So then you would administer, you would call for epinephrine to be given. So we're doing CPR, we're defibrillating, and still the heart rate doesn't convert to a normal sinus rhythm. What do we do next? And that's when drugs are indicated during the code. So the first drug to be given is epinephrine. So when it says follow the same treatment as V-Fib, now we'll go into some more detail. Did you guys have lunch while you were waiting for us to start lecture? No. So we're all hungry. All right, so we'll go for a couple more minutes and then we'll take a break. This is a type of ventricular tachycardia where you see the QRSs going up and then you see them turn and now they start pointing down and then they turn and they start pointing up. And it's called twisting of the points, but it kept its French name. I don't know how to say that in French. Oh, they pronounce the S at the end?
They don't, and French, we don't pronounce S.
Yeah, we're in America, we use yes.
Yeah, but we don't.
That would take that.
I know.
Yeah, we botch it all up here, don't we? My daughter's friend calls wine, you know, Cabernet Sauvignon is a red wine. She calls it Cabernet Sauvignon. So we're not very cultured, okay? Oh, and then I need to give you the treatment for that. So this is typically caused by low magnesium in the body. So the treatment is to give magnesium sulfate. Isn't that amazing that if you are lacking minerals, you can have something like torsade de pointe occur? Did you guys learn about magnesium helping patients with asthma? One of the treatments are when they're in bronchospasm, they're given magnesium supplements.
Yeah, I remember that.
You remember that? Yeah, so can you imagine? So with muscles being relaxed, it takes enough magnesium for a muscle to relax, otherwise you get muscle cramps. And then they found that giving magnesium to asthmatics, they're not in bronchospasm as much. That boggles my mind that something so simple causes all this disease. So. Okay, so this is a good place to stop where we're going to go through the treatment of or what V-Fib is and then how to treat it. So we have just a couple more rhythms left when you come back from lunch. And then we can start on intubation and defibrillation. It's time to rise and shine. Oh dear. All right, I want to start off by showing you a picture of ventricular fibrillation. And in the hospital, nobody says ventricular fibrillation, everybody says V-Fib. So when you see just a coarse wavy line on the EKG monitor, you're looking at ventricular fibrillation, unless you're just looking at loose leads on the patients. So they could be perfectly fine and have this rhythm, and it's not because their heart is fibrillating, it's because the leads are not connected. Doing CPT on a patient makes the EKG look like this. So you want to verify that there should be no pulse with this. The patient is going to be unresponsive. They are not going to have a pulse when the heart is fibrillating. Instead of it contracting normally, it's quivering. And a quivering heart has no cardiac output. It's not forceful enough to push the blood out of the heart. So there will be no pulse. Very unstable rhythm, obviously. So the distinguishing features of V-Fib are, you see a coarse wavy line. So it can start off really coarse, and then if you're watching the patient die, like if they are a DNR and their heart goes into V-Fib, it'll be really coarse initially, and then it starts getting a little less coarse, and eventually it becomes a systole. So when you see this coarse wavy line, there won't be any rate, so you won't see R waves, you won't see P waves, no QRS. Immediately check the patient's pulse. When in V-Fib, the patient will have no pulse. If the EKG lead is disconnected or loose, it may also cause the same look. So you'll have that on your exam when we do the mega code. Same thing. As soon as you see this, you immediately call for the patient and start checking for a carotid pulse. All right, so how do we treat V-Fib? We begin CPR immediately, and the sooner we can get the patient defibrillated, the better their outcomes. So if the defibrillator does not convert them back to a sinus rhythm, obviously we continue CPR. And a drug needs to be given, so 1 milligram of epinephrine. And epinephrine has a really short half-life, like within 3 to 5 minutes, it's already metabolized by the body. So that's why it has to be given so often. So what are the different ways that epinephrine can be given? Do you know? IV?
Injection,
Oh, okay, IM injection. IM, yeah.
inhale. Inhale.
Nebulized? You could nebulize epinephrine, but it's not how you would give the epinephrine during a code.
Oh, during the COVID.
Go ahead.
You can do PO, right?
Is that what PO stands for?
That's by mouth.
Still in down.
So you wouldn't do PO.
No. Yeah, so down the endo tube, very good. So if you're putting it down the endo tube, do you still give the 1 milligram? Or do you double it? You double it. So 1 milligram of epinephrine is the dosage to give intravenous. Putting it down the endo tube, you double the dosage. Can drugs be given to the bone during a code?
To the bone.
I know that sounds barbaric, doesn't it? And it really bothers me to see it done. What's that? Yeah, if an IV cannot be established, so it's preferred that a catheter be placed in the vein and drugs be given via the catheter. But if a vein cannot be attained or IV cannot be attained, then intraosseous injections are given. And that's boring a needle directly into the bone and then running the fluids and the drugs into the bone. I know.
The first time. I hear that.
It is the first time. Yeah, was it during taking pals? I think they bring chicken thighs from the supermarket and they have you inject the femur of the chicken with a needle so you can get used to intraosseous delivery. We don't do that as respiratory therapists, but again, during taking pediatric or ACLS, they have you go through everything for hands-on. All right, so you started CPR, you defibrillated, and still the rhythm did not convert into a normal sinus rhythm. So CPR continues. Now a drug is given, so 1 milligram of epinephrine is given. And you continue CPR, you circulate the epinephrine, and then you repeat the defibrillation. So hopefully now that epinephrine is circulating, when the heart is shocked, it'll respond. If it doesn't respond to the second defibrillation, you continue with CPR. And there's another drug that can be given, and it's amiodarone. So we talked about amiodarone treating Vtac, and it also becomes part of the algorithm for V-Fib. Is there a way for me to make this bigger? But I think once I go into the show, it gets smaller again. Let's try it. It gets smaller again. All right, so I'll show it to you like this. All right, so I'm going to repeat a lot of the things that I've already said, but repetition's good, right? So this is the algorithm for cardiac arrest. So you start your CPR immediately. You start bagging by giving oxygen. The monitor/defibrillator is attached to the patient. And you look at the rhythm, and now you're analyzing the rhythm. So if it's V-Fib, Vtac, then defibrillation is indicated. What if it's asystole? Would you still shock? Defibrillate? No. So test question. What rhythms require defibrillation? There's 2 rhythms. What are they? Very good. So ventricular fibrillation or V-Fib and pulseless Vtac, pulseless ventricular fibrillation. Those are the 2 times that you defibrillate. V-Fib. All right, so you looked at the rhythm, you saw that it was V-Fib or pulseless Vtac, you delivered the shock, and it didn't convert. So now CPR continues, an IV is started, or IO stands for intraosseous access. So if you can't get the vein, then you push the needle into the bone. Okay, after 2 minutes of circulating, you try shocking the rhythm again. If it doesn't convert, what do? It says epinephrine is given. Consider an advanced airway. So that's when the intubation takes place. After epinephrine, shock again. If it still doesn't convert, then amiodarone is given or lidocaine. All right, and then on the side, it talks about CPR quality. It says to push hard and fast. So you want to push in about 2 inches into the chest for the adults. It needs to be fast. 120 per minute means you're doing 2 compressions every second. So that's pretty fast. Allow complete chest recoil. That's one thing to watch out for. I would say that's what happens as far as improper CPR the most, is not come all the way up off the chest each time. Minimize interruptions and compressions. We've talked about that. Avoid excessive ventilation. So when there's air going into the lungs, it creates a positive pressure in the chest, and positive pressure impedes venous return. The word impedes means slows down. So you don't have as much blood returning to the heart if the chest is full of positive pressure. So that's why just bagging like crazy, you're thinking, all right, poor perfusion, CO2 is building up in the cells. We need to bag a lot, get rid of all the built up CO2. And that's true, but it interferes with good blood flow during CPR. So that's why, according to your ACLS guidelines, they're telling you bag about 12 times a minute. So once every 5 seconds at most. And then, of course, during the code at the hospital, if you bag every 5 seconds, they're like, what are you doing? Bag faster. So I understand that. Change compressor every 2 minutes. We talked about that. If no advanced airway, 30 compressions, 2 ventilations. It says 1 breath every 6 seconds. I think I said 1 breath every 5 seconds. And quantitative waveform capnography, so monitoring end-tidal CO2. If the CO2 starts coming up, that tells you that you've got good blood flow and you're bringing the CO2 back to the lungs. But if CO2 return is poor, that means that you're not getting a good blood flow and you're not bringing CO2 back to the lungs. Should I put that in the chat? So I wrote, if untitled CO2 increases, that means you have good blood flow with CPR. So you are bringing the CO2 back to the lungs. Hi, Patty. Good, thanks. If untitled CO2 doesn't increase, it stays low, that indicates poor CPR quality. So the blood is not returning to the lungs and it's not bringing CO2 back to the lungs. Okay, and then for defibrillating, it mentions biphasic and monophasic. Remember 200 joules for the biphasic defibrillator. Monophasic is 360 joules. So when you're defibrillating in the back of the room, that is a biphasic defibrillator. So when you shock the mannequin, you're only going to use 5 joules. So set the amount of charge to 5 joules because that mannequin can only take about 5 joules of shock. But verbalize, if this were a patient, then I would deliver how many joules? 200 joules. Epinephrine, we talked about 1 milligram every 3 to 5 minutes. If the rhythm still doesn't convert, then the next drug given is amiodarone. So intubation, capnography. One thing with untitled CO2, if you're using the colorimetric CO2 capnometer, I guess you say colorimetric capnometer. If the tube is in the lungs, what color should it change to? It should change to purple? Yellow. So remember, yellow is like the sun, it's all happy, it's a good thing, your tube is in your trachea. How many times do you have to bag before it'll actually change from purple to yellow? Yeah, good memory, 6 times. So first bag, nothing happens. Second, you got to bag 6 times before you start getting that color change to occur. All right, so what could happen if the tube is in the trachea, and yet the color, the capnometer is not changing from purple to yellow? What could be happening? There's still CO2 even with a right main stem intubation. If you're in the trachea and bagging, and it's still not changing from purple to yellow. Yes. So that can happen if there's not good blood flow and you're not bringing CO2 back from the cells to the lungs, it's not going to change from purple to yellow. So your tube could be perfect and it's not changing. And that's because you don't have good CPR. Or maybe the patient bled out. You know, they had an aortic aneurysm ruptured and now there's no blood flowing. It's never going to change. What's that?
So the patient wouldn't, so it would turn, the color wouldn't change if the patient has poor perfusion.
Correct. Yeah, so you could be in the trachea and it still doesn't change colors. And that's because there's not good perfusion or good blood flow. So you get pulses back. What do you check? Check a pulse and then you check the blood pressure. And then when you're taking your ACLS course, they talk about reversible causes for why a patient codes or goes into V-Fib, and then you have to code them. And they list it as the 5 H's and the 5 T's. This is not on our exams, but you will have it during ACLS. All right, so if you have to do CPR in a patient who's in COVID-19 isolation, what do you do? You what? You gown up, okay. Do as many people go into the room if it's COVID? No. So you're probably like, there's what, 1 respiratory therapist, maybe 2 respiratory therapists? And then everybody takes turns doing compressions, I guess.
Is this really as accurate still? Because I thought like during the beginning of COVID, it was really poor outcome, but like now they're doing better at it.
They're doing better at preventing the patient from coding, but once they code, it's still poor outcomes. Yeah. Yeah, if they reach this point in their treatment, it's poor outcomes. So when you're using a bag valve mask, you want to use a HEPA filter. Where would you place the HEPA filter? Can you place it between the bag and the mask? Or just on exhalation?
On exhalation.
All right, so I've seen it on exhalation. I've also seen it between the bag and the mask. And then they would prefer not to bag at all because now you're aerosolizing the patient's air. Better to just go ahead and intubate. All right, one of the ways of preventing the aerosolization of the coronavirus into the air during a code is instead of bagging, you keep the patient on the ventilator, or they get intubated and you immediately hook the ventilator circuit up to their tube instead of bagging during the code. So that's just to contain the virus. So once they're on the ventilator circuit, the tube is in, the cup is inflated, all the air is going to go through the ventilator circuit, through the HEPA filter before it goes out into the atmosphere. The other thing is using the ventilator to ventilate the patient during a code. Sometimes it's like pretty messy. Of course, when you're delivering a volume, either in PRVC or volume control, and compressions are being done, you're going to get really high airway pressure. So you're going to have constant alarming, not much volume gets delivered. So the best thing to do is switch over to pressure control or ACPC during the code. So that way you're delivering pressures and hopefully some air gets in without it alarming constantly. And then it says use a FiO2 of 100%. But before the shock is delivered, decrease to an FiO2 of 0.5 or 50% oxygen concentration. And the thought is there's in an oxygen-rich atmosphere, it's possible for a shock to actually spark. And it says turn trigger sensitivity off if possible. The only ventilator I know of that it's possible to do that is to use the servo I and change the sensitivity to a pressure sensitivity and go like a -20 with pressure sensitivity. The servo U, you can't do that. So it gives you a really small window. You can't really lock out the patient. And then what if the patient is prone and they code? Do you flip them over and then start compressions, or do you compress their back? Yeah, so you do compressions on their back. So as long as you're squeezing into the board, squeezing into a soft mattress isn't going to give you a good compression of the chest. But if there's a board underneath them, then pressing into the board will increase pressure in the chest and give you some good blood flow. All right, just a couple rhythms left. This one is called Idioventricular Rhythm. So idio to me looks like idiot. So the ventricles are acting like an idiot, which doesn't really describe the rhythm, but it helps me remember what I'm looking at. The only thing you'll see with an idioventricular rhythm is wide QRSs and nothing else. And the rate is really slow. So remember, if the ventricles are not receiving an impulse from the AV node or the SA node, no impulse. AV node, no impulse. The ventricles will take over and start initiating their own impulses, but they do it really slow, 20, maybe up to 40 times a minute. So these impulses are originating in the ventricles and the impulses are wide. All right, do I want to tell you anything else about idioventricular? No, that's it. And then sometimes idioventricular can have a little faster rate. And it doesn't, I guess that's not important because it doesn't show a picture
Oh,
So-
I have a picture here.
of idioventricular. Ah, perfect. Oops. All right, so it doesn't show much this way. All right, let me pull it along. That's all it is. It's just QRSs. There's no P waves, nothing, just QRSs. So this is an idioventricular rhythm. And how fast is it? So if we count the big boxes between the R waves, we can come up with a rate. So 300, 150, 100, 75, 60, 50, 40. No, this is even slower than 40. So this would still be just idioventricular. This wouldn't be accelerated. So what happened to this patient?
The patient died. Yeah.
Yeah, so this was, the patient was a DNR and died shortly after this rhythm. So there's not much left of the heart, obviously. The only thing left were the ventricles initiating some impulses, and that was it. How come it's not considered a junctional escape rhythm? Because it's really slow? Is that what you're asking?
Like less than 40 also.
40 to 60. But the difference between junctional escape and idioventricular is with a junctional escape, it's going to go through the bundle of His, it's going to go through the right and left bundle branches. So the QRS will look normal. This one's got a really wide QRS. So it didn't start at the AV node and come through. Good question. Okay, and then that's asystole.
That's the easiest one.
Yes, it is easy. Is it possible to have this on the monitor and the patient's fine?
No.
How about if a lead is disconnected?
Yeah.
Yeah.
Yes. So you got to make sure that your patient's unresponsive. You check a pulse when you see this on the monitor, because it could just be that the leads came loose. Okay. And what else did I want to tell you? You check the patient, begin CPR, give epinephrine, and that's it. And then I asked you this question already. Is defibrillation indicated for a patient in asystole? No. There's only two rhythms that you would defibrillate, and those are very good. Okay, so the last one, pulseless electrical activity, is when you have a beautiful PQRST and no pulse. Pulseless electrical activity. So how can you have perfect PQRST and not have a pulse? Typically happens when the patient bleeds out. For a few minutes, The heart tissue is still functioning normally before the lack of blood flow to it starts causing it to go into all these other rhythms we've been looking at. I remember seeing this rhythm, patient came in, stab wound to the left chest. I was working in the ER. He's hooked up to the monitor, beautiful PQRST, no pulse, completely unresponsive. And it's because the knife went through his ventricle and he just bled into his chest. So there's no blood flowing. And of course, that rhythm didn't stay there for long because eventually the heart's not getting oxygen. So it'll start going through, the Pvcs, the Vtac, the Vfib, and then asystole. So what are the causes of PEA? Here it says hypovolemia, hypoxia, high potassium can cause it, hypothermia, and acidosis. Oh, it keeps going. Tension pneumothorax, cardiac tamponade, a big blood clot, thrombosis, or toxins in the body. Is this a question on the exam? No. Oh, okay. So let me quiz you really quick. What is that first rhythm at the top called? What is it? Do you see P waves? No, but the PQRS is normal. So we know that the impulse originated somewhere around the AV node. So we'll call it a junctional rhythm. And now we got three choices for that junctional rhythm: junctional escape, accelerated, or the real fast one. Okay, very good. Junctional escape rhythm. Okay, look at the one at the bottom. It's a 6-second strip. Very good. So that's a junctional rhythm, but we say accelerated junctional rhythm because the rhythm's a little bit faster than what the AV node would do on its own. Okay, what is this one at the top? We've got P waves, but they're upside down. Very good. Junctional tachycardia. Okay, and then the one at the bottom. It's okay if it repeats.
Yeah, junctional accelerated.
Very good. Accelerated junctional rhythm. Okay, what's the one at the top? Got a coarse wavy line. V-Fib, very good. Would you expect a patient to be talking to you if they have this rhythm?
No.
Right. So if this is actually what the heart is doing, then they're going to be unresponsive because they've got no pulse. All right, what about the one at the bottom? Yes, very good. Idioventricular. So the QRSs are wide and the rate is really slow. So that tells us that the ventricles are not getting an impulse from the AV node or above, and they're just doing their own thing. So idioventricular. Okay, what about this rhythm at the top? This is actually a QRS, believe it or not. Not much of one, but that's a QRS. It's a PVC. And there's a PVC every other impulse. Yes. Very good. By Gemini. What if there was a PVC every third impulse? Try Gemini. Good. All right. What is this rhythm at the bottom? Yes, very good. Vtac. So what would you do if you see this on the monitor?
Find the Crash cart?
Get the crash cart. Ask the patient if they're okay, because if they have become unresponsive, you want to check a pulse. And there's a chance that there's no pulse with this. So you may have to start CPR. Okay, what is the rhythm at the top? Trigeminy, very good. All right. So every third impulse is a PVC, and that's called trigeminy. And what is the impulse or the rhythm at the bottom? Asystole. Good job. Okay, what's at the top? Yes, very good. Let's see who's not responding. Gretchen. What is the name of the rhythm at the bottom? Oh, that's right. You don't have a voice. I forgot about that.
That sinus rhythm in PVCs.
Yes. How frequent are the PVCs? No. So this is bigeminy because you have normal PQRST, and then you have a PVC, big fat wide thing that's PVC. So normal PVC, normal PVC, normal PVC. No, it would be just PVCs only. That would be a run of Vtac. So P, QRS, T. P, QRS, T. So you have every other impulse is a PVC. Taylor, what do you think it is?
Talking about the bottom one. It's not.
No, trigeminy would be every third impulse is a PVC, but this is every second.
Oh, the bigeminy.
Yes, very good. Who else is not responding? Marlon. Oh, you've been responding. Mary, what is this? Yes, very good. Junctional escape rhythm. There's no P waves, it's slow, but the QRS looks normal. So we know that the impulse originated at the AV node and went through the ventricles normally. There's just nothing going on in the atria. Okay. Danielle, oh, you've been responding. Who else? Lisbeen. What is this rhythm at the top? Looks pretty crazy, doesn't it?
Yeah.
Good job, Lisbeen. Your voice has changed. I didn't recognize it there for a minute. Yeah, so you just see these wide QRSs. Some of them go up, and now some of them are going down. Now some are going up. So that's the twisting of the points, or torsade de point.
Oh.
So it's a type of Vtac. That's right. Who wants to analyze the rhythm at the bottom? Good. Very good. Yeah, this one's a lot more coarse than the example that was shown in the PowerPoint, but it's still V-Fib. So V-Fib can be really coarse and then it can start getting more fine looking. So yeah, that's V-Fib. Would you expect the patient to have a pulse with that? So if the monitor's connected properly and it's reading, and this is actually what the heart is doing, can the patient be talking to you?
No.
No. That's it. Where to go?